Good evening. Multiple sclerosis is a neurodegenerative autoimmune disease of the central nervous system characterized by fluctuating visual, sensory, and motor symptoms. It involves progressive inflammation, demyelination, and tissue decay, ultimately leading to loss of functional capability. MS has a heterogeneous clinical course, and patients can be diagnosed relapse-remitting or primary progressive. However, the focus of this presentation is diagnosis of clinically definite MS and the insights revealed by advanced magnetic resonance imaging. The most commonly accepted diagnostic guidelines are the McDonald criteria. Diagnosis requires temporal and spatial distribution of lesions with a minimum of 2 separate attacks across different sites. The workflow on the slide shows how dissemination in space and time requirements come together for diagnosis. Lesions can be chronic and acute, or symptomatic or asymptomatic, and one attack must have shown clinical manifestation. Symptomatic spinal lesions, however, are not counted, so lesions must be identified in 2 other sites in these patients. Many syndromes present features similar to MS. 5 to 10% of MS patients are later found to have been misdiagnosed, so it is important clinicians have strong knowledge of the typical neuropathology of both mimicking syndromes and MS to exclude differential causes before diagnosis. Presentation with unifocal symptomatic lesion is clinically isolated syndrome. A typical example is internuclear ophthalmopleuritis. Although identifiable through clinical observation, infrared oculography is more objective. Testing involves patient making horizontal eye movements to targets, and the characterizing sign is desynchronized movement, whereby the adducting eye is slowed. This demonstrates axonal conduction impairments, indicative of demyelinating lesions to the medial longitudinal fasciculus, a periventricular brainstem region. While recurrent clinical events implicating different sites can satisfy diagnostic criteria, MRI's higher sensitivity has made it the primary tool for detecting MS lesions and demonstrating disease distribution. You can see periventricular brainstem lesion on the left here on standard T2 imaging, appearing hyperintense. Temporal distribution in this presentation requires acute lesion in another site. This is evident here on the right with T1 enhanced imaging, and you can see the typical C-shaped rings. MS may thus be diagnosed from a single MRI study. T2 hyperintensities, however, can indicate alternate diagnoses, commonly small vessel disease. There are differentiating features, however, particularly their lack of enhancement properties and typical central location, whereas MS lesions typically distribute peripherally. Significant development has occurred within MRI since the 2010 McDonald criteria revision, and the Magnum's workshop last year proposed a number of modifications. Primarily, the addition of the optic nerve site, the abolishment of additional spinal cord requirements, and the expansion of the juxtacortical site to include cortical lesions. Conventional MRI cannot adequately elucidate the neuropathology of MS. Compared to post-mortem examination, they lack specificity and cannot distinguish between demyelination, inflammation, and axonal loss. Non-conventional MRI techniques address this and can enable earlier diagnosis and reduce misdiagnoses. 7 Tesla scanners represent a significant development in imaging MS. Their superior spatial resolution, signal-to-noise ratio, and contrast enable detailed anatomical visualization and localization of white matter plaques. Additionally, grey matter cortical lesions can be detected and localized. This has particular application for differential diagnosis of neuromyelitis optica spectrum disorder, an inflammatory disorder of the central nervous system frequently conflated with MS. As you can see on the slide, brain imaging under ultra-high field reveals substantially differentiating features. In MS, plaques are almost exclusively distributed in the periventricular white matter, with a small vein through the centre and often featuring a hypointense rim. Uniquely, cortical grey matter lesions are common. Cortical grey matter pathology may reflect the difference in underlying pathogenesis between the disorders. Recent research suggests cortical pathology in MS stems from the pial surface, and autopsy demonstrates subpial lesions are extensive from early in disease course. In vivo detection may significantly contribute to early and accurate diagnosis. By leveraging the different magnetic properties of pathological MS processes, quantitative susceptibility mapping has provided further insight. Lesion containing iron deposition was identified in 90% of MS patients, whereas this feature was absent in neuromyelitis optica. Comparing lesion signal across several non-conventional MRI sequences identified 4 morphologically distinct patterns in MS, hypothesized to reflect age and inflammatory status. A longitudinal study found susceptibility signal changes predictively over lesion stages. Combined with histochemical research, these findings suggest rapid iron accumulation is a distinctive characteristic of MS lesion formation. Spinal cord MRI is not utilized as frequently as brain imaging. However, it has significant clinical value in providing timely, accurate diagnosis. You can see here scans from short tau inversion recovery and proton density imaging, both showing focal lesions much more clearly than T2 scans. Cord lesions in MS are typically cigar-shaped, extending less than 3 vertebrae. Lesions and atrophy are common in the cervical region, whereas significant abnormalities in thoracic and lumbar regions are suggestive of alternate diagnoses. A unique study utilised axial view phase-sensitive inversion recovery to quantify grey and white matter in early MS, which you can see here on the right. Only grey matter atrophy was high. This indicates high axonal loss, implicated by post-mortem studies as a potential key pathological driver of disability. Combining this with fast-field echo imaging allows focal lesions to be depicted in cord grey matter, as well as localization of lesions to individual cord columns, which you can see on the left. Quantitative MRI has shown that lateral cord abnormalities are associated with limb strength decreases and posterior cord column abnormalities with impaired vibration sensation. Additionally, abnormalities to the outer cord can appear early in MS course and before significant atrophy is present. This provides further indication of pial inflammation's involvement in disease progression. The growing use of MRI has led to increasing identification of MS-like neuropathology in people who have never displayed symptoms of an MS attack. This is referred to as radiologically isolated syndrome and does not come under the McDonald criteria. The Magnus guidelines recommend criteria be applied such that diagnosis can be made immediately upon clinical attack. Other researchers argue that when imaging meets all other criteria and clearly displays features strongly indicative of MS, then clinical manifestation should not be required. Presence of subpial cortical lesions or simultaneous MS-typical brain and spinal lesions are strongly predictive of progression to clinically definite MS, and early diagnosis is critical for prognosis. Finally, recent research has wide-reaching implications for central nervous system immune diseases such as MS. Historically, the central nervous system has been considered immune privileged. Last year, 2 independent studies confirmed lymphatic vessels in the dura mater, demonstrating the immune system does indeed extend to the brain. Future research investigating the implications of this in MS could result in fundamental changes to understanding of the underlying neuropathology and hopefully lead to diagnostic and prognostic improvements for people living with MS. Thank you.